So I'll get started. All of you know me by now. This is my second presentation, which is pretty close to my first presentation, so I'll give you a little update about what I've been doing. And if you remember from the first talk, we're looking at cone imaging in patients with retinitis pigmentosa who are receiving the intraocular implant that has CNTF treatment inside of it. These are some nice eye pumpkins if you're feeling ambitious tonight. So our research question, as I said, we were looking at implant in one eye and sham surgery in the other eye. And our outcome is going to be difference in cone survival at 12 months after receiving the treatments. So some of this is just review from the last talk, because I know there's a lot of detail about eyes that not everyone is familiar with. So I talked last time about how the cone mosaic in the retina is highly organized. And this is important for our project in order to use that as an outcome. So you can see close to the fovea, the cones are very tightly packed, and as we get out farther in the retina, you can see they sort of space out, and there are some small little intervening rods in there. And this is just another way of showing the same information. So as we go out farther from the fovea, you can see that the distance between cones increases in what's sort of a linear relationship, and this data has actually collected from the same imaging system that we're using for our project. So that tells us kind of the range of normal cone spacing. And so near the fovea would be there, farther out, and even farther out. Make sense? And so, as I said last time, so we're looking at just a very small portion of the retina with this technology called Oslo, and that is allows us to get a very high resolution picture. So this is kind of blown up from the last. We see the fovea there, and then we're looking at these particular regions of interest in different parts of the retina, some close, some more peripheral. And if we zoom in to the regions of interest, so you don't need to know this, but that just stands for upper left and upper right, different parts of the retina. And you can see the little cone mosaic here is very well resolved with this technology. And so right now we're actually doing data collection looking at these cones. And what we do is have 3 people do manual grading of the cones by placing these little crosshairs on each cone profile. And then I'll show what I'm going to explain today is the way that we calculate the cone spacing. And we're going to compare how the different graders look at cone spacing to see how consistently this outcome can be measured. So what we do is after this profile is generated, the computer calculates the distance between every pair of 2 cones. So this cone to this cone, this cone to this cone, this cone to this cone, etc. for every permutation of the cones. And the thing is, in order to do a good job with this, it requires actually a lot of training. So it's not only understanding the images and where the cones are, but also understanding how to interpret what the computer generates after that. So I started by just training with normal retina images because they're a lot more easy to interpret than diseased retinal images. So this is a healthy eye. And this is one of the regions that I did. So as you can see, it's pretty straightforward. Those bright areas are the cones, and there's a pretty regular mosaic. This is a different region in the same eye, and it looks like the crosshairs are a lot bigger, but that's actually just because we're zoomed in. You can see how the cones here are a lot larger than the cones closer to the fovea. That's because they're more tightly packed in this image here on the right. So we'll focus on this one. I'll show you how we calculate the cone spacing. So what happens when the computer generates all of those permutations of the distances between every pair of cones, we get a histogram, and this x-axis here is the distance between the two cones, and then the number of cone pairs at that distance. So the way we interpret this histogram with this peak right here is that that is the distance between, the shortest distance between the cone pairs. So in other words, it's a distance from a given cone to its nearest neighbor. And we can see in this example, it comes out to about 1.37. So I know it's a little confusing. Does anyone have questions about what I just said? Or does that make sense?
That makes sense. I feel like this histogram, the fit sort of isn't the best fit. You can sort of see additional peaks to the right of that.
Exactly. So great point. So first of all, these additional peaks are probably, so if this is the distance to the nearest neighboring cone, this is probably the distance to the second nearest neighbor. So it's nice when we see a clear first peak, second peak, third peak, because it means that we're clearly identifying a regular mosaic. One of the challenges of interpreting this graph is actually that we fit this blue curve here manually, and there's some difference from one grader to the next in how they think that the curve best fits this peak. Did that answer your question?
Mm-hmm. But there must be a way to do that just sort of automatically with the computer, right?
That's we have come to the same conclusion and are kind of working on how to make that happen. So for this retinal image that I showed previously, these yellow points here are the data points that we generated by looking at a histogram for each region of interest. And you can see that, as expected, this one falls within the range of normal because it was a healthy eye. And this red data point there was just the one that was from the previous slide here. So now it gets a little bit more challenging when we're working with the patients with RP that are in our study. So this is a 25-year-old female. This is the montage that we generated from imaging her eye at baseline. And you can see right away that just the quality of the image is not as crisp here. So it's a little bit more challenging to identify what we think are unambiguous cones. The image here for her happens to be a little bit better near the fovea, so you can see it pretty clearly there. But we'll focus on this one. So same thing, we generate the histogram. We calculate the distance to the nearest neighboring cone based on that curve. And for this patient, actually, despite the fact that she has RP, her values essentially fell within the range of normal. So you can see already that there is some interpretation involved in this data collection, like Kunal pointed out. There's how you fit the curve to the histogram, interpreting that. There's also, the question of when the image quality is poor, how do you identify cones? So one of the things that's important for our outcome in order to make sure that it's a valid outcome is assessing how well our 3 independent graders look at the same image. But in order to do that, we're using a statistical measure called ICC. It's basically compares one group of data to another group of data and looks at how well they agree with each other. So we're looking at the ICC for our 3 different graders. And you can see these are some examples. This is one subject, another, and another. These are all the regions of interest here, and then the cone spacing. So you can see for some regions of interest, all 3 graders essentially calculated the same cone spacing, so it's very reassuring. You can see for other regions, there is a difference in how people interpreted the image. And up here, the ICC ranges from 0 to 1, with 1 being perfect agreement. So, for these particular examples, that's not bad to have above a 0.9 or a 0.85. But when we get down to the image quality, that can really influence how well the graders agree. So this is ideally what we get out of our imaging system, but for a variety of reasons we can get images that are very difficult to interpret. That can be due to cataracts or disease activity, floaters, problems with our machine. There's just a whole litany of reasons why the image quality cannot be good. So I'm going to show you some examples where we discovered problems between the three graders. So this is an example, this is a baseline image. So this was one grader putting their crosshairs on the cones. This was a second grader and a third grader. And so you can see here, there's a huge difference between calculating a spacing of 0.8 and of 1.5. That's an order of magnitude, and the ICC for agreement in this image was 0.55, which is not really acceptable in terms of using this as an outcome measure. Here's another example. You can see right away, it's just very difficult to see a clear cone mosaic here. So this was grader A's interpretation, grader B, and grader C. So again, this has a very poor ICC, 0.2, which means they really didn't agree at all. So I didn't put a slide about this, but so we've looked at this for all of the grading that's been done so far, and because there were certain regions where the graders had really different ideas of the cone spacing, we've had a fourth person come in and be the arbitrator to decide, which one of the three graders was maybe too far off, and we had the fourth person redo the cone spacing from scratch.
The specific regions that are analyzed by the various graders, are they done essentially kind of at the same time as the other graders? Like specific region, will that be like the fourth image that every single grader does?
Yeah, they are.
Okay.
Yeah, so what happens, the computer just goes through the list of regions, identifies the exact coordinate on that, image of the retina, and that's where you count the cones. So there is consistency from grader to grader in terms of how they do it.
And when they do it. So I imagine they get better at identifying
Yeah, so
cones
that's
as...
another issue. So, as I said, it requires a lot of training, and the more cone spacing you measure, the better you get at it. And the way, I'll talk later about how we're trying to think about that and work with that issue in our interpretation. So as I said, the timeline for our project, we're doing the rest of the data collection right now. Ideally, we're going to analyze the data and have an abstract ready by December 6th, which is fairly ambitious given how much is left. So this is, I did not mean to animate those. This is just shows where we are in terms of the,
I should really see the names.
I don't know how that happens. But so these are our subjects, and then, so we've done all of the cone spacing and baseline, and we're working through doing the 6 months. And for the 12 months, we have collected all of their images, but we still need to process some of those before we can do the cone spacing. Okay, so this is a nice little Halloween costume if you're looking for ideas, though maybe a little too much to put together in just one day. So again, our primary outcomes, we're going to compare the treated eye to the non-treated eye at 6 and 12 months. We talked about some of the considerations here. Image quality can really influence the results. And looking at how the graders vary, so there's how they interpret the cone spacing, how they interpret the histogram. And one of the things that we've tried to think about is having a training protocol, getting at Krista's question of, people get better the more they do. So what we'd ideally like to do is have people complete a certain number of practice images before they're allowed to grade data from the study. In the real world, we'd have them do a whole bunch before becoming a qualified grader. At this point, we're working under a tight timeline, so we'll have to balance those two things. This is another Halloween costume. It's kind of creepy though. So the abstract that we'd like to have by December 6th is for ARBO, which is the big ophthalmology meeting every year. And hopefully we'll at least have the, we might actually hold the 6-month data and do the 12-month data first in order to have that for ARBO. This is all my favorite Halloween costume. They have all the muscles in it. So thanks again to everyone that's helped along the way, including Dr. Duncan who's here. And the rest of our lab has been working very, very hard to process all of these images and count cones all day. Anything? Nothing?
Have you looked at the, or maybe this was related to the ICC, the intergrader reliability for the histogram selection? Because I imagine that that's probably more reliable than the cone spacing.
You would think. So I didn't really get into as much detail of the histogram as I could have, and this is part of the challenge. So there's a, we have to fit this curve manually, but there's also different ways of displaying the histogram, basically the number of bars that it puts up, and that's also manually chosen. So that's probably the biggest source of variability. And it's because when we calculate the ICC, that incorporates both the way they pick the cones and the way they pick the histogram. Right now, we don't have a way of breaking it down into one or the other to see which is more of the problem, though I think we think that both contribute significantly.
And then what do you use, what software system are you using to calculate those?
So the histogram is generated in MATLAB.
Okay.
This is just run from MATLAB scripts, and then the actual cone selection is custom software that was developed for those projects.
I think MATLAB has functions that automatically calculate those, right?
I'm sure there's a way to program it. Right now this is how we've done all of the baseline data, so it's probably how we're going to continue to do that. But I think in the future, that's definitely a consideration.
Just really briefly, some of the challenges with automating everything is that if you show some of those more ambiguous images, if you wanted to show one now, a computer will very readily pick up white spots and say this is definitely a cone.
Yeah.
And we rely instead, though, upon trained graders because sometimes they are cones, but then there's other things that look like white spots that are not cones.
Sure.
And so we also correlate this information with a cross-sectional image of the retina so we can identify exactly where the cones are first and foremost to say, is this a cone? Are there even cones in there? And then we kind of have to do some pattern recognition that is more sophisticated than a computer algorithm has to date been capable of doing.
No, I totally agree. I think in terms of
tricky. I mean, we would love to automate the whole thing and just push a button and have the answer at the end. And we've actually tried that, but unfortunately, a lot of times it just fails.
Yeah. The way it's interesting because we do have like when this region pops up before I put the crosshairs on, there is an automatically generated of what the computer thinks, just kind of for fun at this point. And it's really when the images are very crisp, it's pretty good actually. And I'll just have to move a few of them. When the image looks like this, it's it doesn't make any sense at all.
So it's hard. It's harder than I wish it were.
No, I think it makes sense for the cones to have to do it
You're
with
talking about
graders,
for the
but for at least the
histogram,
histograms, that seems like something you can sort of standardize in terms of.
That too, though, when you have a beautiful mosaic, you get these lovely little peaks, and it's so easy. But
sometimes if they're kind of, you would look at it with your human eye and go, well, I see the curve, but there are kind of bars missing where there should be, and so, the challenge is relying on a computer to make that assessment. You probably have to go in and correct it anyway a lot of the time.
Have you looked at the readers in terms of, is there one, within the readers, is there one outlier?
So we did look at that. There was a person who was an outlier for a certain set of images, and that's part of why we decided that it was okay to have a fourth person come in and regrade those particular images. But it always begs the question of like, how much do you want to mess with the data after you've collected it, because there's always the possibility for introducing bias that way. And that's why, as I was saying in response to Christo's question, we're trying to come up with a standard way of training everybody.
And actually, this protocol has evolved over time. That people that were doing it at sort of the very beginning didn't have as much experience sort of knowing how to do it as we have now. So we're kind of evolving as we go. But we have some really talented biostatisticians looking at this with us, and they're looking for things like bias amongst the graders. And they're finding actually that some of them, there's no consistent bias in one, like it's not like one person always grades high or low. So they're actually treating each of the graders as an independent variable. So like of the universe of graders, each of them is going to be a teeny bit different, and they're incorporating that into the statistical model.
Right, and what we did find for that one outlying grader was not that they were always consistently off in one direction, it's just that their measurement differed significantly from the other two.
And then the other aspect that you mentioned, the one of image resolution, is that expected to get better as well?
Well, it's a fickle system. Not only does it depend on the optics of the eye of the particular patient, which can be challenging, say if they're developing cataracts, but it's also just, it depends on how the machine is working on a given day. And, we've run into issues with that over the summer, which now seem to be improving. But
we're at a point where like it either performs beautifully or fails, spectacularly. So as long as we get, the other thing that's sometimes tricky is when there's high refractive error, a lot of cylinder, if we, and that's up to us with trial frames, don't get the correction as, optimal as it possibly can be, and rely too much upon the system to correct for the, less irregular astigmatism, it's asking the system to do a little bit too much. So for people with really high refractive errors, with tear film abnormalities, with cataracts, with epidermal membranes, with floaters, there's lots of things that systematic edema, a lot of things that can make this very challenging in eyes-sensitive cases. So it's a lot harder in eyes-sensitive. Even though sometimes the cone spacing is not that they've all even lost all that many cones. The cone spacing might be normal. It's just they're not all perfectly visible all the time.
Just two questions.
Sure.
One is, if you have a view that has an ICC less than your desired threshold of 0.8 or 0.9, is that excluded from your overall analysis? And two, if you know what proportion of your views have an ICC of less than that threshold that you go as well?
Sure. So right now, we've looked only at the baseline images because that's all we have the cone spacing for. We don't have a set threshold at which we're going to throw out data, being because it's still the whole, part of the point of this study is to validate this as an outcome measure. So we want to know if it doesn't work. That being said, when we did identify a grader that was consistently way off from the other two, we had a fourth person come in. And when we had the fourth person come in, it really did improve the ICCs. What was the second part of your question?
What proportion of the images or the views have those low ICCs? I'm just curious.
It's only a handful that are really poor. We've gone back and graded the image quality for all of those, and we're finding, those are often, like with this example, where it's more of an image quality issue per se than someone, really failing to identify the cones. It's just because, you can't, some cones like this is clearly a cone here, but when you get to things like this and this, you can kind of make an argument in your head either way. But I would say it's, less than 20% that are really not agreeing very well.
And the image quality of this particular view, if you have one view, will all the other views in that same eye kind of have similar qualities?
Not necessarily. So like the example I showed a while ago, this frame was not great, but this frame was okay. This is the same eye. So it has to do, when the machine looks at different parts of the retina, because the resolution is so high, there are different optical aberrations in different parts of the eye. And that's part of what's challenging. Like Dr. Duncan was saying with astigmatism, we have to correct for that. And if we don't do that perfectly, then that can influence the results. Or, say if someone has a cataract that's only on part of the lens, you may not get good images through that, looking through that part of the lens, but be fine somewhere else.
Next question.
Sure.
What
For the sample size you're using for these patients, is there any exclusion criteria for like regards to like the current medication use? I know sometimes the cataracts and floaters are causing image abnormalities and poor resolution. So would you exclude anyone who's had any diagnosis or anything or not medication?
Yeah. Definitely. So in my last talk, I listed all of the exclusion criteria, and that's exactly right. So we excluded people that we thought ahead of time it would be very difficult to get good images on. And sometimes we would even bring people in for their baseline visit, and it was just so difficult to get good images that we had to exclude them. So, we also originally were going to exclude people that had really high myopia, so very nearsighted, and I think some of those people ended up making it through because we needed more patients, and so they're challenging to image.